and welcome everyone to today's webinar, Motivational Interviewing, a Chronic Pain and Addiction Medicine Perspective. So I'd like to introduce our speaker, Keri Alexander. So Keri graduated from Otago Medical School in New Zealand in 1994, and she moved to Melbourne in 1999. So she's worked for many years as a community GP, where she became an experienced methadone prescriber. She completed a graduate diploma of family medicine at Monash University and was an accredited supervisor of GP registrars. In 2007, she graduated from the RACP Addiction Medicine Training Program, obtaining fellowship of the Australasian chapter of addiction medicine. Since then, she's worked as an addiction medicine specialist in both public and private sectors. So Keri has been an addiction specialist, addiction medicine specialist at Turning Point Eastern Health since 2012, and is the director of addictions training. She is also one of the clinical panel, she's also on the clinical panel of WorkSafe. She is one of the consultants at DACAS, which is the Drug and Alcohol Clinical Advisory Service. And most importantly, she is one of the consultants who works at the ODPAC clinic of the Ambulatory Pain Management Service of Eastern Health. So the ODPAC clinic is specifically for opiate dependence pain assessment, and that's based in the PJC. So great to have you along, Keri. I hope everyone can see you. We've spotlight viewed you. Thank you for taking the time. I think that everything that you say is awesome, so I will be listening intently. And over to you.
Oh, thank you, Carlos, for that very, very flattering introduction. So, and thanks for inviting me along. That's fantastic. So there will be breaks along the PowerPoint slides to discuss stuff as they come up. So motivational interviewing, it historically, initially, was a form of counselling for people with addiction issues, but and also for smokers. So this was designed for health professionals such as initially counsellors to help patients with addiction, as well as GPs to help patients to quit smoking. But it's been found to be a fantastic, really, really cost-efficient and time-efficient tool for any health professional to use when dealing with patients with chronic health issues. So, and the nice thing is you don't need any qualifications to do it, and you don't need to know tons about it to just start using it immediately. So I'm hoping at the end of today's session that everyone here will go away with a few little snippets that you could start trying to use immediately. And the feedback I've had from that I've heard from lots of other busy health professionals doing like 15-minute consults with patients or whatever with chronic health issues, so that when they just use even just one or two little tricks or strategies rather from motivational interviewing, it actually saves them time, because they can actually quickly find out what's the most effective way to get the outcome for their patient. Now, I'm going to just stop my video briefly so we can focus on the screens. And Carlos is doing it for me. So it's time for change, everyone. And yeah, so this is just like a teaser of what motivational interviewing is. So it's a really useful concept. Basically, it's a useful solution and yet a fantastic tool in our invisible toolkit that we all have as health professionals. And it's really great for using with patients who have chronic issues that we keep seeing again and again, and they resist our advice. Often such patients are labelled, or we consider them to be unmotivated, or they lack insight into their health condition and their health needs. But also, it's really useful to be aware that behavioural change psychologists, millions of dollars has been spent researching motivational interviewing in the field of psychology, say that us humans, our motivation for any change fluctuates. It keeps changing, and it can actually be influenced by all sorts of things. And one of the things that's been well shown in the research is that when an authoritative figure such as a health professional uses an authoritative or paternalistic style, such as, you've got to start exercising or your pain's never going to improve, that unfortunately increases the patient's resistance to implementing the behaviour change that us health professionals are trying to get across. Leo, just switch to the next page, please. Thank you. So its foundation is in a fantastic model of called the cycle of change, or stages of change model, which is by Prushka and Di Clementi, who I think invented this in the 70s or 80s. They were behavioural change psychologists, and it's been quite groundbreaking. So this is a cycle that goes round and round and round and round. So today I'm going to think about people who have chronic pain, and one thing I might think about is a patient with chronic pain that isn't doing their exercises that they've been prescribed by their physiotherapist, or every health professional is like, you've got chronic back pain, you spend your whole day lying around on the sofa watching Netflix. If you want to get better, you're going to have to actually start walking or do your physio exercises, or both. And then the patient just doesn't do it. So this applies to all of us humans. So there's always a moment that we're pre-contemplative, and that might mean like we're not even interested in change, that doesn't apply to me, or, what's the point? My back's pain. I went for a walk once and my back really hurt, and in fact, actually it felt a bit worse afterwards, so why bother? Then at some point, naturally, there's something happens, or things can happen where we start contemplating a healthy behaviour change. So that might mean maybe I become a grandparent, and I'd really actually, it would be sad to miss out on being able to play with my grandchildren when they're toddlers in the playground, or pick them up and lift them up and give them a hug. So that then means I, as a person with chronic pain that lies around on the sofa all day, I might contemplate, actually, maybe I do need to change some stuff. Maybe I should actually start doing what the physiotherapist has told me to do. So I'm just going to mute someone. Can I just ask everyone, if you're not muted, just to make sure you're muted? Thank you. And then the next stage is preparing to change, preparing to do the behavioural change. So that might mean thinking, okay, I better, get my old runners out from the back of the cupboard, dust them off, find some socks, maybe, start thinking about what I'm going to start doing. And then the next step is action. So that might mean, actually, I'm going to get up and go for a 10-minute walk before breakfast tomorrow. And then the maintenance is maintaining the behavioural change. So that might be maintaining the exercise program that the physiotherapist put in place. And then there's a point, a fork in the pathway. The next thing is usually relapse, and that's relapse back into the unhealthy behaviour, be it lying around exercising, lying around not doing in a sedentary way, not doing the exercises, or it might be going back to taking handfuls of opioids when it just all feels too hard, or it might be giving up this quit smoking plan and going bust and breaking out a stash of cigarettes and starting smoking then. And then after that is pre-contemplation again, which is like, oh, I could quit, I'll do it another day, or I don't need that, or it's not going to really make much difference anyway. And it goes round and round and round until someone, once they're at the maintenance stage of it, if they maintain it long-term, day in, day out long-term, then that's called long-term maintenance or long-term recovery. If there's any questions about that, please enter it in the chat, because it's a really good thing to discuss later. So the nice thing in motivational interviewing is, in a hospital health setting, that we don't have time to actually work out exactly where someone is. But the reason I'm going through this right now is to know that this is kind of part of the history of motivational interviewing. And if you're clearly aware where a patient's at, that's helpful, because no matter where they're at, we can still therapeutically engage them and as far as addiction is concerned, do harm minimization strategies so that when they are moving around the cycle, they've already linked into the appropriate health services or know where to get help. Carlos, can you check the next page, please? So I've just put this here because it's our lunch break. It's sort of nice to shift our focus. And next photo, excellent. So the nice thing about motivational interviewing is, like I said earlier, you don't have to do a full-on course. You don't have to become a qualified counsellor or psychologist. It's based on the, it's essential that it's used in the spirit of motivational interviewing. And sometimes if that's all we can muster or bring to our consultations with our clients, it's actually really good. And sometimes it's actually good enough. So the spirit is based on collaboration, which is the collaboration between the patient and the health practitioner. And if I'm meeting someone only one time, so say if they're in hospital and they've never met me, I've never met them before, and I've only got one assessment, one consultation with them, I will try and bring the spirit of collaboration to that consultation, which includes joint making decision as a framework. However, in reality, that means that I offer evidence-based medicine and make recommendations for evidence-based healthcare, and I will provide information about that. They don't have to take it up, but that does not mean that I'm going to keep prescribing or authorising or permitting things that are dangerous. So in my particular clinical experience, by definition, every patient I see has an addiction issue, otherwise they wouldn't see me. So if they want dangerous doses of opioid medication that could accidentally kill them in their sleep, I'm not going to condone that because I don't want to kill my patients. But I offer good medicine and truly try and bring a spirit that we're collaborating together because I'm committed to them having the best possible health outcomes. And I try and bring that spirit to my consultations. Also, is in motivational interviewing is acknowledging the patient's expertise about themselves and their lives. And most patients with chronic pain and nearly every patient with an addiction has a history of significant trauma, possibly depression, anxiety, and grief and loss. And I cannot even begin to imagine what that is like for the patient in front of me. So I bring that respect front of mind when I'm seeing patients because I do not know, and I'm not the one to judge them. So sometimes I will even tell them, and people here have seen me work, sometimes I'll even say that to the patient: you are the expert at your life. Here are the options. Here's what I'd recommend, but you know your body, you know how things fit in with your life better than anyone else. Given all that, what do you think would be the most realistic option in this scenario? Carlos, can you jump to the next slide, please? Another thing in the spirit of motivational interviewing is the term that's used in the literature for this is called evocation, or concept of evoking. I personally am not a big fan of that word, but what they mean by this is that the health practitioner activates the patient's own motivation. So we evoke the patient's motivation for change. And the way we do this is we evoke their reasons for change. Now, I've specifically written in values because the reasons most humans choose to change our behaviour is when it aligns with something, a strong core value. And core values, the word values can mean different things. But in this concept, it actually means they're quite different to goals. So a goal might be to be pain-free, but the value might be to spend time with loved ones. Might be love, honesty, contributing, caring. Those are kind of core values. There's many other values as well, but if we can help the patient to consider what, they might want to be pain-free, but actually it's because they want to get back to work, and they want to get back to work because they're actually really lonely at home and they miss their workmates. So that's actually about connection and caring and community and collaboration. Those might be their values. So the next part in the spirit is actually, as a health practitioner, honouring the patient's autonomy. So that's summed up as, it's up to you. Like, oh, that's kind of a rude way of saying, but like, it's actually up to you. So I might see a patient who's on huge doses of, dangerous doses of oxycodone for their chronic pain, and they're at risk of dying in their sleep. And I can be really clear that we cannot authorise that because I care about them. We now know there's good evidence that people are, 11 times more likely to accidentally die in their sleep on those doses. That they deserve good quality care based on the latest research. We're unable to recommend that because it's not safe. But what we can offer is to slowly taper the dose down, or to switch them over to Suboxone. And it's up to you, and you don't have to decide today. You can go away and have a think about which option, but in the meantime, we're going to start tapering down. So that's just an example of the kind of script I might use with a patient. So in the field of motivational interviewing, there's a useful, simple acronym called OARS to remember, which is to ask open-ended questions, and you deliberately use affirmations and reflect back to the patient and summarise. However, having said that, I learned the hard way as a medical student, open-ended questions, if you ask the wrong ones, oh my God, you're there for hours. Doesn't work. So it might be something like, what is your understanding about your pain management plan? And just finding out what their understanding about it is. And the affirmation is, my understanding of what they mean in the literature is actually praise for something good. So someone might be really aggressive and demanding, and the praise could be, wow, you strike me as someone that really cares about your health, and you're, are really good at advocating for your health, and you'll stop at nothing to get good health care. Or it might be validating their feeling, and that it's actually okay to have that feeling, like, wow, you seem really angry today, and that makes a lot of sense from what you've told me. That makes total sense that you'd be feeling angry in that situation. And that also would come on to reflection. And then the summarisation could be along the lines of, you understand that you've got this pain management program, but you find it really hard to implement because you don't have money for the medications, and you don't have a car to get to the chemist, and you have to rely on your husband, but he works really long hours, and often he doesn't get home from work till after the chemist. And that's an example. You able to jump to the next? Yeah, okay. So there's also an acronym used in the motivational interviewing literature called RULE. And that is the hardest thing for me, is the R in RULE, which is to resist the righting reflex. So that's to resist my urge as a health professional to tell the patient or try and convince the patient of what the best thing for them is, because that will actually paradoxically backfire and reduce the chance of them actually making some changes. U stands for to understand their motivation. L is to listen with empathy. And E is to empower the client. Carlos, are you able to do the next? Yep. So there's my bookshelf at home at the end of lockdown last year. And you have to jump to the next. Okay, so this is a really, really useful example that us health practitioners can use in a brief consultation context, like 15, 20 minutes. So it could be something like, tell me what you understand about the concerns that your treating team have about your pain medication. Hear what they say. And then I'll provide the information. So, for instance, in that context, it could be, well, the latest research shows that people on your dose of opioid medication are at unacceptable high risk of accidental death, and that is often caused by stopping breathing in your sleep. And that would be absolutely tragic for everyone, including everyone that loves you. So I'm telling them something. Then I would end the consult really quickly with asking them another question, because the process of asking before we give them information, which we need them to have, and then asking them again actually makes it really sink in a powerful way where they're feeling empowered and they're hopefully not feeling overwhelmed and defensive. So another useful question to ask at the end is, if you were to leave, after you leave here, if you had to quickly tell someone else what you learned from your time with me today, what would you tell them? And it's a really powerful way to check in that we've done a good job by making sure they've gotten the information we need to get, and to actually deepen their understanding of the information that we've provided. So some examples of that, which I would commonly say, is you're the expert at your life. So I'm actually not sure I'm the best person to judge what will work for you, but I can give you an idea of what the evidence shows us and what other people have done in your situation. Another question which can trigger change thinking in patients could be, how would you like your health to be in 5 years' time? Another question could be, what could be the advantages of exercising more for you? Thank you, Carlos. You read my mind. Now, here's some tips I found from a program for using motivational interviewing for patients with chronic pain. So this was a nice kind of stripped line for opioid medications, really. So it says, trying to avoid the patient feeling trapped or cornered, because then they get defensive and then they justify why they need their opioids. So this example says, patients who expect drugs to control their pain are usually disappointed. With or without chronic pain, my patients who are doing better use multiple approaches. Let's talk about what might help you become more active and do more things that you enjoy. So this brings us to the next slide, which is, again, so this is one of the key things: resist the righting reflex. So that's the reflex in us health professionals to be the right experts, to feel that we have the right to dictate to the patient what they should be doing, because it backfires and makes them more stubborn and defensive. The next key thing is to understand the patient's own motivations. And for most humans, it's actually about connection, feeling valued, connected, belonging, and contributing, which makes people feel wanted. And another key one is empathy, ensuring our patients feel that we're empathetic with their situation. And the fourth one is bringing the spirit of empowerment, that the patients on their journey through the health system, all patients with chronic pain have seen multiple health professionals, and there's always a complex situation going on, invariably. And so their interaction with us is one of dozens and dozens, if not hundreds. So if we can use our brief time with them to bring the spirit of trying to empower them along their health journey to make healthy choices. These are just a couple of references. I'd highly recommend the first article if anyone wanted to read more, because it succinctly summarizes how to apply this in brief consultations for patients with chronic health issues. And then I've got a couple more slides, or maybe one more. So this is my key messages I like to bring to every consultation with every patient. And I'm constantly having to remind myself to aspire for this. But it's to bring dignity and respect and hope. So every interaction with every patient and their carer, I try to treat them with dignity and respect, so that they feel treated with dignity and respect, because we're going to get a much better outcome with that. And also, like, by definition, every patient I see has addiction issues, and they're chronic and long-term, and lots of them also have pain and mental health issues. And often there's a loss of hope. But if all I can give them is hope, that's got to be a good thing. And sometimes that that might be for an individual, that might be the key to feel there is hope. It is worth my while actually getting off the sofa, turning off the TV, dusting off my runners and going for a walk. So,
Keri, I have some comments and questions, and I
right.
think they should come. The questions should come. I've actually observed you doing a consult, and like a very quick consult actually. And one of the things that I noticed, I've also done some like motivational interviewing training with the Heart Foundation, and then sort of dabbling in it over the course of my career. And one of the things that I found with the way that you do things is that you really build rapport very quickly. And that's sort of the thing that you achieve initially before you even move forward towards like the true consult thing. But my question is actually that I wanted to, you said that it's time saving. And I did mention in the chat that that's probably what most of the audience is probably thinking, but how is it time saving where you really have to, have these open-ended questions, affirmations, reflections, those sorts of things. Like, how are you saving time? Because it seems like a long conversation.
Yeah, so I suppose it's about being creative and customizing things. But an example might be like I went to meet a patient as a one-off in a hospital elsewhere, and we didn't have much time. So what I always do to help bring dignity and respect to the patient, but also it makes me more confident, and so then hopefully I instill confidence in the patient and me, is I always read the notes first. It's not possible to read the whole notes, but I might read a summary or a recent discharge summary or a recent medical report, and I might read the most recent entry. And if they're a regular patient of mine, I always read my most recent entry. So when I see the patient, I can confidently say, I saw this guy say, "Hi, Joe Blogs, welcome. This is who I am. This is my name. Your doctors have asked me to see you because they were really concerned about this. Now, it's my understanding that you're in hospital because of X, Y, Z, and have I got that right?" So actually, I've deliberately asked them a question. So suddenly they feel, hopefully, to create a sense of collaboration. And that's a really quick question. And they might say, "Yes, that's right." Or they might say, "Actually, no, there was something else." And I'm honest. I haven't had time to read your whole notes, but from what I have read, this is what it looks like to me. Have I got that right? And I'm really open to being wrong as well. So I find that a really, really quick way to build dignity, hope, empathy, and that's all just in like one sentence sometimes. So that would be one example. Like I said earlier, I've long given up on asking really open-ended questions because I've been trapped as a junior busy doctor with someone babbling on for hours literally. So it'd be much more brief ones. So that patient I saw the other day had so many health issues. So I was saying, what is your main health issue at the moment? Or if there's lots of things, like if there was 3 things that the hospital could organise for you, what would they be? Or, what are your key 2 priorities? So it's a really quick question, but actually I then quickly get really useful information, and I actually haven't wasted tons of time, and I haven't suggested a whole lot of stuff that's not even going to work. So that's just some examples of how it can actually quickly save time.
Beautiful. I just wanted to make a couple of comments as well. So I really like that you spoke about the stages of change, and I think obviously that's one of the guiding principles of motivational interviewing. And I wanted to sort of like comment about the fact that what I tend to do when I'm sort of working with patients is that I'm trying to determine where exactly they are in that stage of change, and then what I'm trying to do is once I've determined that, then I can start to if someone is pre-contemplation, then why would I be speaking in action or in planning when they're in the pre-contemplation? So I would base some of the things that I discuss with them on that particular stage, because it would probably be it would put off that patient if you start talking about action and that sort of stuff, or it's not going to be a very useful conversation. And I guess the other thing about the stages of change that sort of normalize things and kind of guide what we do, with our patients, is that relapse is so common. It's so ebbing and flowing, and we just need to make it normal, because I feel like there are some patients that come in and they're like, they go through those stages of changes with you and they're like, Carlos, I'm really fantastic. You've done so well. And I'm like, hang on. This is the whole circle. There's relapse. So part of my therapy is actually making sure that they're aware of that relapse. So then if the relapse happens, then they are prepared, psychologically, and they're prepared, for that relapse. Any sort of comments there, Keri?
Yes, I think that's brilliant, especially when we've got a strong sense of where they're at in the cycle of change. But some health professionals who use this a lot in consultations say they don't have time to work out somewhere where they're at on that day in the cycle of change. And so they say the good news is, even if you don't know, we can still try and apply things, even if it's just like ask them a question, then provide the information, which is tell, and then ask them another question. That can actually be really powerful. But absolutely, in the field of addiction, we do actively try and work out where they're at on the cycle of change. I actually love giving people hope, because sometimes I feel that's the only thing I can offer. So, for instance, in the field of addiction, if someone is pre-contemplative, so in that case, I would usually only ever meet them if they're in the hospital for something unrelated. In that situation, I would try and give them a sense of dignity, respect, let them know where services are at if and when they ever need them, and try and provide some empowering health information. Like, for instance, if they inject illegal drugs, I would make sure that they know where there's a needle syringe program, and offer to check their veins to make sure they're not infected and they're healthy. And if they're all scarred up, I will even teach them to find another vein that hasn't been scarred up, so it's going to be safer for injecting, because I care about their health and their veins. And that often is quite powerful, because sometimes that's one of the few times they haven't felt judged or criticised by a health professional. But actually, by doing that, often I'll get a really strong history from them. And so in the addiction field, we can keep offering harm minimisation when they're pre-contemplative. Between contemplative and contemplative, there is usually a pain point. And the term I was trained in is so it'll come to me. Carlos or someone might know the term. It'll come in a second. But I think of it as a pain point, and it's a cognitive dissonance, that's the term. And it's actually extremely psychologically painful. So a textbook example could be someone that's been smoking long term, and they're pre-contemplative because, they knew someone that, was, is 96 years old and has been smoking their whole life, and they're as fit as a fiddle, and, I've got to die of something anyway, and, or I could quit whenever I want. And then there might be a brief moment where maybe someone they know who they used to smoke with has just been diagnosed with lung cancer, and they're the same age. And suddenly there might be this incredibly painful moment, like, oh my God, am I going to give myself lung cancer? And it's really it's pain. It's psychological pain. And us humans cannot sustain that pain for long. So our brains do this incredible psychological trick to get out of that painful state. And the easiest thing our brains can do is to go back into pre-contemplation, which is denial. And our brains are fantastic at denial. Or the other thing is to then flip to contemplation, to motivate to action. Like, actually, I don't want to die of lung cancer. I'm only 49. I've got kids. I actually am going to need to do something about this. So that's a really useful thing to know will come for everyone. So my ideal thing is that when they get to that point, they already feel that they've got a health service that they already either have a relationship with, or that they trust and have that they trust that they're a reputable professional service.
Jeremy's asking, how can we use motivational interviewing to have the conversation with our pain patients who we feel need to consider addiction medicine pathways, which is a conversation that we have on a regular basis? Thank you.
Oh my gosh, what a cutie. Okay, so that's a really good question. So the kind of conversations I have with people is, and I deliberately do not undermine their trust in the other health professionals they've had along their journey, because that's never good for patients. It just makes them scared, and then they don't know who to trust or what to trust. So I have different scripts I use. So a common script I would have is, so we're talking about high dose opioids really, would be, I'd say the latest research shows that anyone on higher than, on your dose of opioids, and whatever it is, I might even work it out. So anyone on higher than 70 milligrams a day of oxycodone, so that includes everything you're on. If I add it up, you're on more than 70 milligrams. You're actually on 200 milligrams a day. The latest research shows that lots of people with chronic pain on that, it actually, we now know it can actually affect the pain, the nerves and the pain pathway to make them extra sensitive to physical pain. And that's kind of a back to front. We didn't used to know that. It's new information. So now lots of people are switching over to a different opioid pain medication that's much, much less likely to do that. It's called buprenorphine. It's also much safer because we also know people on your doses of oxycodone or morphine or whatever it is have 11 times or 12, it depends what dose they're on, 11 times higher chance of accidentally dying from the medication toxicity. And when it often happens in people's sleep because if they stop breathing and they just don't wake up, and that would be catastrophic. And you deserve good, and a common line I say, and I'm pretty sure Carlos has heard me say this, is I often say to these patients, you deserve gold standard healthcare. And often their pain is no fault of their own. So that might have been a horrific thing. Like you have, your pain, you're living with terrible pain, and you deserve the latest evidence for gold standard treatment. And we now know what it is. And as far as your medication goes, we know that your pain management will be much better and much safer if we follow this protocol and actually either slowly reduce your oxycodone down to only 70 milligrams a day, or switch you over to buprenorphine, which is most people say they're not sedated, they're not lethargic anymore, and that their pain management is actually no worse or often even better. So that's a common, I call it my sales pitch. Often when I use it at the end of the sales pitch, not everyone, but at least 80 or 90% of people are asking to go on buprenorphine straight away.
Yeah, I've actually been in a consult with you, Keri, and heard you say that sort of almost exact same sales pitch, and it's really a very therapeutic way, really empowering. I know that the clients tend to sort of, especially because often you give them the choice, you sort of say, look, there's a couple of pathways that we could choose or that we could try, or this is what this is what the evidence says, and this is where I would start, and then we can relook at things a bit further down the track to try and get that OMED number down, but the way that you phrase it is giving the patient, I guess, the driver's seat and being able to make that choice of, do you want to go down this pathway or this pathway? This is going to be, better for your life. But yeah, I've witnessed you phrasing it in that way, and I do think the clients really take to it.
Keri, I've got another question from one of the people watching. Would you differ your approach in motivational interviewing when working with patients from low educational groups or those with diverse ethnic backgrounds? And this person actually commented, in my clinical practice, I've noticed some cultures believe those with chronic pain cannot be fixed and are too quick to allow their injured family members to be dependent on them rather than gaining independence.
So with that last sentence, did I understand it correctly? You said that the patient's family believe that the patient's chronic pain will never be fixed?
Yes, correct. And encourage dependence rather than independence. But the main question was, do you differ your approach for motivational interviewing when working with patients from low educational groups or diverse ethnic backgrounds?
That's actually a brilliant question. And the two groups are quite disparate, but of course, there's overlaps. So I've spent most of my professional career working with patients from very, very low socioeconomic backgrounds. Huge portions of my patients have been homeless and are either illiterate or functionally illiterate, and living in total poverty. So I actually love using it in that patient group, because for some of them, the feedback I get is that they just feel so great. They often are so grateful. So it makes me feel good. I've done a good day's work. They're so grateful that they've been treated with such dignity and respect. And I deliberately, for all patients, and especially that client group of very low socioeconomic backgrounds, use things like, sometimes I'll even say to them, you seem like a really smart person to me. So I'm wondering, with these options we've given you, which ones do you think would work best in your life? So that could be an example I use. And for lots of them, it might be a long time since they've been called smart, maybe never. And maybe their IQ isn't the highest, but they are the expert, or it might be very high. I just don't know. But they are actually the expert of their life. And I'll often tell them that. So then they know where I'm coming from. With culturally diverse backgrounds, I haven't thought about it in the construct of that question, which is a really good one. So that's kind of a new, I haven't thought about it in that situation, but I haven't modified in that. But I deliberately use it for carers as well, because I think we do our patients a really good service if we treat their carers with dignity and respect as well, because they are working together as a team, and then we can be part of a collaborative team on their health journey, even if our length of duration in their treatment is only 10 or 15 minutes. So I haven't, because it's so new, I haven't thought about that thing about the family culturally encouraging dependence, presumably from the best of intentions out of love, but as we all know, for chronic pain, that can get poor outcomes. So I haven't thought about it in that context. But Carlos or someone might have some more ideas than me about that.
I'm happy to say a few things. I have noticed that definitely, cultural backgrounds definitely do play into things. But I think motivational interviewing still has a really good place in that you're asking questions. And so you might ask it of the carer of, well, in 10 years' time, where do you see this? And, is this something that you want to keep, providing this level of care? Or would you like your family member to be able to get a better quality of life? And, and sort of phrase it a little bit more directive around, the future, and where do they actually see themselves, and what does their family life look like in the future. Again, it doesn't help if they're sort of in that closed off mindset, but again, it's just opening that door, and it might only be moving them from pre-contemplation to contemplation, and that might be the most that you get, but at least it's opening that journey. And then maybe the next encounter with a health professional, it might move them that next step as well. So we're just part of that journey.
I was going to ask, there's another question from one of the participants. Do you have any good techniques for those that are really stuck in the pre-contemplation phase and are finding it difficult to contemplate any change?
Well, because my field is addiction. So in addiction, I always focus on therapeutic engagement with the service, not necessarily me specifically. So, for instance, I work at Turning Point Eastern Treatment Service and in outpatients. So they might be referred here by someone. So I want them to begin to trust that this is a professional service that they could turn to if and when they needed it in the future. So I still use motivational interviewing, and it would include empowerment. So about empowering them by letting them know what services are available if and when they need them. In the field of addiction in Melbourne, as an example, as we all probably know from the media, for the last couple of years, we've had a medically supervised injecting room. There's only one in the whole of Victoria, and it's in Richmond. That is an ideal model of a really powerful health service that's being delivered for people who are pre-contemplative. They can go there, they can they're less likely. In fact, I think they've had no deaths since it opened on the premises. So it reduces the chance of people dying while they're using. They provide bloodborne virus screening. So it reduces the chance of people spreading bloodborne viruses such as hepatitis C and HIV in the community. They provide sterile needles, so it reduces the chance of them catching and then spreading those viruses. They can opportunistically address other health issues while they're there, and they constantly provide information about if you want to go, if you don't want to live like this anymore, if you don't want to have to go and keep doing whatever it is you have to do to be able to buy heroin twice a day, 7 days a week, we can put you on buprenorphine today or tomorrow. Just have a think about it.
Yeah, that's cool. I suppose that's a bit like the music festivals where they do the drug testing, hand over your drugs, we'll test them, we'll tell you what's in them, that sort of thing. So it's got a really useful role, but some of the community don't, and they really resist against that.
Yeah, which is the difference between a moral approach to addiction versus a health approach to addiction.
Yes.
Keri, I've got a question. So I wanted to see if you would be open to speaking about the writing reflex, and I think it's a really good one to share with people because I think that we probably do, we do paternalistic really well, especially like as a physiotherapist. We say this is what you got to do, boom, 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 and then when they come back and then they go, oh, I haven't done these exercises. And then you say, why? These are really, really important for you, rah, 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 rah. And this is probably how I take you when you say the writing reflex. Are you able to sort of expound on, the world of the writing reflex and, how people may be paternalistic? Like what kind of routine paternalistic sort of conversations do clinicians have that they should be avoiding?
I'm just trying to open a great resource on my computer just behind me, but this firewall that wouldn't let me get into Zoom isn't even letting me open journal articles. So I think I'm going to have to phone up IT, which actually has some really good examples of the writing reflex. I just think about me personally. I, as everyone who's worked with me knows, I've got strong opinions. And so resisting the writing reflex is actually a big challenge for me. I have to, and I'm not perfect at it by any means. So I have to keep resisting my own internal reflex to be right, my own internal reflex for me to be the expert and the authority in my consultations with patients and their carers. So I can't think of some examples off the top of my head. I'm just so irritated that this great resource I've got here isn't opening. But I was just wondering, maybe Carlos or Michelle or someone else that uses it might have some examples.
I've got tons of examples of me being, very paternalistic. This is what you got to do. And the other thing is just to say that there are some people that react really well to paternalistic. Like, just tell me what to do and I'll do it. And then they come back and then they've done it. So I think that there's nothing wrong with paternalistic. It's a tool, but then also not being paternalistic is really important for the type of people who are ambivalent. Sue, Michelle, do you guys have, Eddie, do you guys have examples of when you guys have been paternalistic?
I just want to comment, Carlos, I totally agree. I think you've got to match the intervention or the style with the person. And I used to be very much like, what do you think? What do you think? But there are people that really want direction and really flourish with it. And others that if you suggest things to them, they're like 10 reasons why I can't do it. So you need to be really, clever with where you work with the person.
Yeah, I think our pain management program is rather paternalistic in that we have a very regimented routine every Tuesday and Friday. You got to participate in this, then you're going to do your meditation, mindfulness, then you're going to do your gym program, and then you're going to participate in the education session. But I think as a clinician over the years of being in the pain clinic, if a client who says, I can't do gym today, I'm too sore, I am just not having a bar of it, I'm going to go outside and have a smoke, or I'm going to sit in the tea room and have a cup of tea instead. Going, okay, no worries, exploring the reason why, and then giving them a few different options rather than just accepting what they want to do. You go, I respect that that you're suffering in this way, but potentially, can I get you a heat pack? Are there any mindfulness practices that you want to review and practice with one of the psychologists or the allied health assistants? Or is there one stretch that you're happy to do? And giving them a few different options and giving them autonomy is a lot more helpful, I think. Yeah.
Well, that actually sounds like it would say to me that it would save a lot of time.
Yeah, sure.
Because then you quickly actually, from what you've described, that's a really quick way to develop a collaborative relationship. You're bringing the spirit of empathy and empowerment to that person in that whole conversation that might take only 5 minutes.
Mm.
Yeah. You might find out what else is going on. Like maybe they're having PTS flashbacks that are being triggered by something in the room or whatever.
Mm.
Yeah.
So Jeremy is asking, how do you balance focusing on patient choice within motivational interviewing while avoiding feeding into an enabling cycle? Very good question.
Mm.
Yeah, no, that's a really good question. So once again, I'll just bring it back to my specialty because that's what I know best. So I won't feed into denial. I bring the spirit that I actually believe that every patient I meet deserves good quality healthcare. So I bring the spirit that my role is in their health journey, that they're the expert at their health, they're the expert at their life, and they're on a journey through lots of things, including the health system. And I'm one of many cogs and multiple different wheels. And so if I can bring to that, that I can offer evidence-based treatment or evidence-based medications and recommendations for that. That's what I'm offering. So lots of patients I see with chronic pain are on high dose opioids, otherwise most of them wouldn't be seeing me. And so lots of them are insisting that they need it, they can't come off it or whatever. I'm not even and they might have all these valid reasons, and there's this and that, and they can't function without it. So I won't even feed into that. I will actually focus on you deserve good healthcare. This is what we now know. Like, this is the latest information. This is what we know. And also we know that most people who go through this change are actually pleasantly surprised. They actually tell us their pain is no worse, and some of them find their pain's better, and it's a lot safer. So these are the different things we could offer. We could look at this path or that path. Go away and have a think. You don't have to make a decision today.
Fantastic. I just wanted to say a big thank you to Keri for coming in and presenting to us and for being the type of clinician that we all, really look up to. The great thing about you is that you've been cornered into doing another couple presentations and webinars with us later this year. So cannabis use disorder and opiate use disorder. So hopefully peeps can join us for that.
Fantastic, everyone. Thank you for inviting me. I look forward to seeing you next time.